And first, just to focus on some basic genetics. So the androgen receptor gene is actually on the X chromosome. So if you take a step back and you think about this, there's 2 copies in a woman and 1 copy in a man. So that's a little bit ironic. Of course, in a woman, it's deactivated. And there are these 8 exons which comprise the gene. And of course, as you know, the intronic sequences are spliced out to form the mature protein when it's translated. And the protein has these 4 domains. The red domain, which is encoded by exons 4 through 8, is the ligand binding domain, followed by this blue area called the hinge region, and then this green area called the DNA binding domain. And this purple area is the N-terminal domain, which is the transcriptionally active part of the molecule. And there's been at least 22 AR splice variants discovered in humans. And the update was from the East Coast Dream Team, where they used RNA-seq on 150 CRPC biopsies, and they basically found 22 different splice variants using RNA sequencing. And we and others have focused on AR-V7 for several reasons. The main reasons are that it's the most abundant in human clinical specimens, and it's the most common. Now, the 3D crystal structure of the full-length androgen receptor is partially resolved and partially unresolved. The ligand binding domain is pretty well figured out because it has enough alpha helixes and beta sheets to form a 3D crystal structure. And this pocket here on the top right is the actual ligand binding domain within the C-terminus. And this is where DHT, the natural ligand, binds. And this is the same pocket where all the anti-androgens bind. So flutamide, nilutamide, bicalutamide, enzalutamide, ARN-509, ODM-201, every single one of those drugs binds to the same pocket and displaces DHT. So it competes with and displaces DHT. The hinge region is then followed by the DNA binding domain. And this year at the PCF, at least I heard for the first time that there are preclinical studies of DNA binding domain inhibitors. And then the N-terminal is drawn as a squiggly red line. And the reason is it's because it's internally disorganized. So this crystal structure has not been resolved. It doesn't have enough beta helixes and alpha sheets to allow for this crystal structure to be resolved. And one of the reasons is it keeps changing shape. And it keeps changing shape depending on the co-activators and co-repressors that bind to it. But it also changes shape based on ligands that bind to the ligand binding part as well. And that's been very difficult to target. The key thing about the NTD, though, is that it's the transcriptionally active part of the molecule. And there's a sequence within the NTD called the AF1 activating function 1 domain. And if you create a deletion mutant and you delete the AF1 domain, the AR loses 99% of its transcriptional activity. So this is the key engine driving transcription of the AR. Almost all of the splice variants retain the N-terminal, but lack the entire C-terminal, including the ligand binding domain. And some of them contain the hinge, some of them do not contain the hinge. AR-V7 happens to not contain that area, but some of the other splice variants, like the 567ES, they do retain that part. So my colleague Jun Luo, who was the senior author on this paper, spent about 3 years of his life working about 20 hours a day on a CTC assay for these patients. And the key here was, this is not a DNA marker, it's an RNA marker. So we needed to have a CTC technology that would allow you to capture CTCs, isolate the RNA, and then do an RT-PCR without the RNA being degraded. And when we looked at a number of technologies, the one that we actually, that June found was the best one for high quality, non-degraded RNA was a so-called ADNA test. And the company making that was a German company called Adnogen. And that's actually the assay that we used, because again, this is a splicing variant, this is an mRNA event, it's not a DNA event. And we developed the circulating tumor cell assay, and we decided to do a small prospective study. So you guys have seen these slides. In the 31 patients receiving enzalutamide, 12 of the 31 had the AR-V7. A couple things to highlight here. These little dagger marks above or below the curves represent patients that were receiving enzalutamide that had previously received abiraterone. So this shows you right away that the chance of having a lack of response was higher if you had received abiraterone before, and the chance of having AR-V7 was higher if you had received abiraterone before. The second observation, which was really interesting, at least to me, was that we had this one patient that had a about a 30% PSA reduction that lasted about 2 months. And this was an early clue that this biomarker was not going to be an all or none. In other words, it was not going to be an absolute negative predictor of outcomes. And this sort of gave us some insights that there could be a small proportion of patients that will respond, at least for a brief time. And the subsequent unpublished data from Hopkins actually confirms that there are some patients that can achieve, even in one case, a 90% PSA response despite AR-V7. So again, it's not a perfect biomarker. And the Kaplan-Meier curves for radiographic progression, free survival, and overall survival were quite distinct, depending on whether the person had AR-V7 positive or negative CTCs. But one thing which I want to highlight here, clinical or radiographic progression in the AR-V7 positive patients was about 3 months, median of 3 months. So these patients present a very, very lethal phenotype, and they progress very rapidly. And if you look at overall survival, another thing pops out at you, which is that the median survival was 9 months in these patients. And even more concerning, every single patient had died by 18 months, every single patient. So again, this really reflects, I think, a very lethal phenotype. Now, this doesn't answer the question about whether AR-V7 is a driver or passenger. I think the jury's still out, and even I'm not sure. But it tells us that there's an association with a worse outcome. In our institution, abiraterone was usually used at that time prior to enzalutamide. So here you can see that the dagger marks, there's only 4 of them. So only 4 patients that were receiving abiraterone had previously received enzalutamide. And that also might be one of the reasons why we only found this in 6 out of 31 patients. In this particular case, every single one of these patients had a primary resistance. But the other interesting thing here is these 2 patients here with the black bars. So these are patients that had wild-type AR only and did not have any splice variant. And those patients also had primary resistance to abiraterone. And in fact, neither of them had received enzalutamide first. So these are patients with castration-resistant, what we would call first-line treatment. They would be expected to respond to abiraterone. Even if you had an AR-V7 assay, these guys would have been AR-V7 negative, and yet absolute primary resistance to this drug. So that's actually very telling, and we're actually trying to figure out what these guys might have to make them resistant. We haven't figured it out yet. Now, the interesting thing about these Kaplan-Meier curves is, as you remember, most of these patients were receiving abiraterone for the first time. They had not received enzalutamide. And yet, the AR-V7 positive patients, most of which had not received a taxane or enzalutamide, in the presence of AR-V7 also had a very, very rapid progression, median of 3 months. And in fact, every single patient had progressed by like 3.2 months. And again, the survival, even though these patients were otherwise treatment-naive CRPC patients, median of about 10 months. So this kind of, at least to me, was very concerning that if the AR variant was present, so potentially, regardless of other clinical factors, that phenotype might be very lethal. And this was actually the first, what I would call a validation study. This was a group in Germany. Steinestel was the first author, Schrader was the last author. And this was published a few months ago. So what they did was they actually also used the adenogen as well, CTC isolation. And then they developed their own RT-PCR primers, which were different from the Hopkins primers. But they were also primers that were specific for the AR-V7. And jumping right to the bottom row here, they found AR-V7 negative CTCs in 19 patients, AR-V7 positive CTCs in 18 patients. And while the chance of obtaining a PSA response to enzalutamide or abiraterone was much higher in the AR-V7 negative patients, they did see 1 patient out of 14 who had a robust PSA response, more than 50%, despite the presence of AR-V7 using the same CTC technology with different primers. And this patient actually happened to respond to abiraterone. So again, this is beginning to paint the picture that, I think we need to tell this story. There are going to be people that respond. It still might be the minority, but it's not going to be 0. So the question is, what about microtubules? And this theory came along around 2-3 years ago, that the androgen receptor actually, in some cases, might require the microtubules to traffic from the cytoplasm into the nucleus. And they even found the binding protein, which is this protein called dynein motor protein, which binds to the hinge region of the AR protein. And then the AR can use that to sort of traffic into the nucleus. So about a year after that, we decided to actually test that in our patients. It was actually a no-brainer. And we used the same protocol as our last study, but we expanded it. And we basically enrolled 37 patients receiving the taxane. In 30 cases, it was docetaxel, and in 7 cases, it was cabazitaxel. And the bottom line is, as many people have seen already, we saw responses here irrespective of AR-V7 status. So for example, these 3 patients here, that patient there were all AR-V7 positive, and they all had robust PSA responses. Now, if you actually go into the weeds and you actually look at the percentages, so the chance of responding by PSA in the AR-V7 positive patients was 41%, and the AR-V7 negative patients was 65%. So yes, the chance of responding to the taxane in the AR-V7 negative setting was a little bit higher, but in the positive patients, it was not so close to zero. It was fairly robust, 41%. Progression-free survival, did diverge here. Not as much as in the previous trial where we looked at abiraterone and enzalutamide, but there was a small separation. The p-value was not significant, but the caveat is we only had 37 patients. So if this was 100 patients or 200 patients, this difference probably would have been significant. So the biomarker is slightly relevant in this setting, but maybe not as relevant as in the AR therapy. And when we combine the data from the 2 trials, these were not concurrently enrolled trials, and this was not a randomized trial. So that's the caveat. We showed that when you superimpose the 2 curves, the AR-directed therapies represented by the dotted curves separate more based on the biomarker, and the taxane curves separate less. So this marker might still be prognostic potentially in the setting of taxanes, but it's much more relevant in the setting of AR-directed therapies. And again, in a hypothesis-generating subset analysis, we showed that in the AR-V7 positive patients, the chance of progression was about 5 times higher with abiraterone or enzalutamide compared to taxane. However, in the AR-V7 negative patients, hazard ratio was 1.02, so essentially equivalent responses to either AR-directed therapy or taxane therapy. And again, just very recently, these papers are probably going to start popping up one by one. This is the first, what I call a validation of the chemotherapy data. So this is the group from Rotterdam. The last author was Ron DeWitt. And here they looked at 29 patients, all receiving cabazitaxel. So this is cabazitaxel, not docetaxel. And these patients had all received docetaxel before, and like 80% of them had also received abiraterone. Okay? Now here, they didn't use the adenogen, they used the cell search. So different CTC capturing technology. But in this case, although the CTC technology was different, the primers were the Hopkins primers. So they used a different CTC kit with the primers that we published. And they saw no difference whatsoever in radiographic progression-free survival. Again, in the setting of cabazitaxel. So while our study showed a small difference with docetaxel, here there was no difference whatsoever with cabazitaxel. And there were PSA responses both in the AR-V7 positive and negative subsets. So these are my conclusions. AR-V7 can reliably be detected in CTCs. Now you have to have a CTC present to do the test. So you can't do it right now using cell-free nucleic acids. It would have to be cell-free RNA, but people are working on that. But if you have a CTC, you can do the test. If you have AR-V7 positive circulating cancer cells, you're probably not going to respond at a great frequency to abiraterone and enzalutamide, but you still have a chance of responding to taxane, and that chance might be 40%, 50%, and it might be even better with cabazitaxel. So in the AR-V7 positive patients, if these data are further confirmed by other groups and other prospective trials, those patients might do better with a taxane. In the AR-V7 negative situation, of course, AR-directed therapies would be the treatment of choice because they're easier to give with less toxicity and equally efficacious. So if this ends up being true, and we don't know if it will be, but if it does, then this could potentially be a treatment selection marker. And I kind of like this term more than the words predictive or prognostic, which have been very confusing. Treatment selection, does this help you make a decision between treatment A versus treatment B? And we haven't had that to date in prostate cancer. So do I think this is ready for clinical prime time? Absolutely not. Absolutely not. Okay. Now, having said that, my friend Steve Plymate wrote this editorial, and of course it wasn't his assay. He didn't have a vested interest, so he got away with saying this. And he predicted that, again, with all the caveats that we understand, and if this was validated, this would be sort of his way of thinking about the future of how this test could be used. So when a patient becomes castration resistant, Dr. Plymate suggested doing an AR-V7 test. If the AR-V7 status was negative, he thought that an AR-directed therapy would be a reasonable first choice. After the patient progressed, he suggested retesting that patient. If that patient was again negative at the time of progression, he could switch to the alternative AR therapy. But if the patient had converted to positive during the course of ABI or ENZA, that patient should then receive a taxane. On the other hand, if the patient was AR-V7 positive at the first signs of CRPC, then that patient should probably start with docetaxel. He then could be retested. We have seen cases where under the influence of docetaxel, the AR-V7 status can flip from positive to negative. And if that occurs, he suggested at that point in time, patient could receive ABI or ENZA. But if they remain positive, then he might receive a second taxane. Again, this is just looking into the future. We're not ready for this now, but this could be how the biomarker could be used. And then my last 3 slides are going to be about therapeutics. So this is, the most interesting thing to me. So what type of agents, other than taxanes, might be in development to target AR-V-driven cancers? And I'm going to talk about these 3: galeterone, AP506, which is the first N-terminal domain inhibitor, and then niclosamide, which was sort of an accidental discovery. So galeterone has 3 mechanisms of action: CYP17 lyase inhibition, like abiraterone and orteronel. Also has AR antagonism by blocking the ligand binding domain. And finally, a third mechanism, which is degradation of the AR protein. And it degrades not just the AR full length, but the AR variants, including AR-V7. And I'm not sure if Mary Ellen is still here, but Mary Ellen presented this data on 7 patients from the phase 2 galeterone experience. And in this assay, they used the Epic Sciences platform to evaluate circulating tumor cells for what they called C-terminal loss. So this was a bit different from our assay because they looked for immunohistochemistry of the N-terminal and the C-terminal. And then they looked for patients that had presence of the N-terminal but absence of the C-terminal in the same cell. And they called that C-terminal loss. That could be because of a splice variant. We don't know which one. It also could be caused by other aberrations. But in those 7 patients that had C-terminal loss, 6 out of 7 had a 50% PSA response to galeterone. So the company got very excited by this, and they jumped right into a phase 3 study, believe it or not. And this is the design of the phase 3. It just opened last week. This is going to be a biomarker selection trial design. So patients who are with castration-resistant prostate cancer have not received enzalutamide, have not received abiraterone, and have not received a taxane. So true first-line CRPC patients are going to be tested for AR-V7. If they have positive CTCs, and those CTCs are AR-V7 positive, they are then eligible for randomization. If they don't have CTCs, or they have CTCs which are AR-V7 negative, they're excluded. And then they're randomized 1-to-1 between galeterone and enzalutamide. QIAGEN was basically tasked to develop a CLIA certified assay for this trial because, of course, you're using the biomarker to select treatment. And they did that in about 6 months. And the assay is ready, it's up and running. And it's being offered on 3 continents. In the US, it's in North Carolina. In Europe, it's in Belgium. And in Australia, it's in Melbourne. So this is going to be a global study with 3 central labs. And the interesting thing here is that in the pre-chemotherapy, pre-abiraterone, pre-enzalutamide patients, only about 50% at best are going to have CTCs in the blood. And of those, only about 10% of the CTC positive are going to be AR-V7 positive. So they're going to have to screen between 2,000 and 2,500 patients to get 150, which is their sample size. So the sample size is going to be 150 men. Now, the FDA, in an unprecedented move, has not accepted but encouraged the use of a primary endpoint of rPFS, radiographic progression-free survival. And they were not really required to show an overall survival difference, and they were not really required to have overall survival as a co-primary endpoint, just have it as a key secondary endpoint. So this could potentially, if the trial is positive, this could be the first rPFS trial. Now, AP506 is an analog of AP001. AP001 was discovered by Marianne Sater at University of British Columbia. She founded a company called ESSA Pharmaceuticals. When you ask Dr. Sater why she named the company ESSA, she'll tell you it's her father's initials. And she said, I named it after my father, so I would have a very high bar. I didn't want to disappoint him. And I said, are you sure? She said, yes. So she named it after her dad. The cool thing about this drug, to my knowledge, this is the first agent that's about to hit the clinic that inhibits the N-terminal, okay? And it does so by forming a covalent bond. In fact, it forms two covalent bonds with two amino acids, which have not yet been disclosed because there's a patent which is being filed, but two amino acids which are a certain sequence apart from each other, and it basically binds to the first amino acid just by chance, and then when the conformation of the rest of the N-terminal gets into a certain shape, then it binds the second covalent bond, and once the two bonds are made, it basically locks the NTD into like a frozen structure. And of course, the cool thing here is the N-terminal is present not only in the wild-type AR, it's also present in every single one of the splice variants, including AR-V7. So, and the preclinical data with this drug look pretty darn good. And of course, if this is true, this would be expected to basically abolish all androgen receptor signaling, not just wild-type signaling, but also aberrant AR signaling. Now, this is a design of the phase 1. It was presented as a trials in progress poster, and it will be starting either in the next few months or by the latest in January. And the FDA has approved this design, and they have an IND. It's going to be for patients that have progressed after abiraterone or enzalutamide, one or the other. And one additional taxane is permitted but not required. So a patient that has received abiraterone only is eligible, enzalutamide only is eligible, enzalutamide plus taxane is eligible. If they've received both Abi and Enza, they're not eligible. If they've received more than one taxane, they're not eligible. And the phase 1 is going to be 30 patients, and then the phase 2 is going to be a large expansion of 120 more patients. And then the final drug is niclosamide. So the group from UC Davis published a study where they looked at a drug library of 3,000 FDA-approved compounds, and they were looking for inhibitors of cell lines that contain AR-V7. And they found this unexpected hit, which is this drug niclosamide, which is an anti-helminthic agent. This inhibits a tapeworm that lives in the gut. And in fact, it's a very good tapeworm agent because it's not absorbed very well. So it remains inside the lumen of the gut. It can kill the tapeworm. But it turns out that a number of AR-V7 expressing cell lines, including this cell line called C42, it actually decreases PSA transcription more so than enzalutamide. As you can see here, enzalutamide doesn't have much of an effect on this cell line. And at the protein level, in the 22RV1 cell line, which also expresses very abundant AR-V7, increasing concentrations of niclosamide decrease at the protein level AR-V7, but somehow seem to spare degradation of the full-length AR by a mechanism that's not completely understood. But this degradation appears to be proteasome-mediated because when you use proteasome inhibitors, it doesn't degrade. And in this 22RV1 xenograft model, they showed that enzalutamide had no effect. We already knew that. Niclosamide caused tumor restriction, but the combination of niclosamide plus enzalutamide was the most effective. And we've talked a lot about Ki-67 at this meeting, but the Ki-67 with just enzalutamide alone in this animal model basically was very high, didn't do anything. Niclosamide caused a reduction, and the combination caused a further reduction. And one of our fellows, Michael Schweitzer, who is now at the Fred Hutch, designed this study, and this is also going to be an AR-V7 selection design. It's a phase 1/2. So this is for patients which are abiraterone resistant that have progressed on abiraterone. They're going to be tested for AR-V7 using a University of Washington CLIA certified assay for AR-V7. If they're AR-V7 positive, they're going to be enrolled. And then they're going to receive concurrent treatment with enzalutamide, plus 3 escalating dose levels of niclosamide. Remember, this has a very poor oral absorption, and so they're using very high doses to see if they can overcome that problem. So 0.5 gram 3 times a day is the first dose level, 1 gram 3 times a day, and then 1.5 grams 3 times a day. And so the goal here is to see if there's safety, first of all, and secondly, if there's any clinical activity and if there's any conversion of the AR-V7 positive patients to negative. Remember, all these patients are going to be AR-V7 positive at enrollment. That's my last slide. CTCs can be used to reliably detect AR-V7. It might be a mechanism of resistance to ABI and ENZA, probably not as much to taxanes. So therefore, it might be a treatment selection marker if the data are validated. There's a number of ongoing studies, and in the interest of time, I didn't have time to get into those. Andy Armstrong is leading one. There's other phase 2 randomized trials, both in the US and in Europe, which are being done to validate the marker. But to me, the most interesting and promising part is, could this be turned into a liability? So could the expression of AR-V7 be targeted for therapeutic gain? Jun Luo is basically the mastermind behind all this work. He basically came up with all the ideas, and I just executed them. And he should get a lot of the credit. And of course, it takes a whole team to get this work done.
Quick question, Emmanuel. So at the PCF retreat, Gerhard Attard presented some really interesting data on AR amplification, perhaps predicting or at least being strongly associated, like your work, with ABI resistance. But he didn't look at V7. He was looking at cell-free DNA. And you've looked purely, mostly at RNA. Haven't been able to look at copy number or DNA. I just wonder if you could comment on what you think the relationship between AR amplification and the variant might be.
So there is probably upregulation of the antigen receptor. Whether that upregulation is due to copy number changes or whether it's due to upregulation at the mRNA level, at the transcription level, is unclear. In our assay, we could only look at RNA. So the sort of abundance of RNA for AR was much, much higher in patients that had AR-V7 positive, and it was much, much lower in patients that were AR-V7 negative. But of course, we couldn't assess whether that was due to amplification or overexpression per se. One interesting thing is the concept of AR variants versus AR mutations. So in Gert Attard's study, he was focusing on not only amplification, but also these mutations in the DNA binding domain, and he showed that that also correlated with inferior outcomes. We've been doing RNA-seq on the small group of patients that have enough CTCs that gives us enough RNA to do not just the RT-PCR, but the RNA-seq. And the RNA, at the RNA level, it's cDNA, we're not finding that many cases of ligand binding domain activating mutations and coexistence of AR splice variants. So we've only found one case so far of a patient that has both AR-V7 and an activating mutation of the AR ligand binding domain. And Arul Shanayan, in his Dream Team effort, also presented a poster at the SPORE meeting, also suggesting that the two events might be largely mutually exclusive, although not completely mutually exclusive. And so that might potentially speak to sort of the one or the other, the AR mutations or the AR variants, potentially being drivers. And if the cell has one or the other, it may not need both.
Hi. I'm interested in the conversion of AR-V7 positives to negative back again. You mentioned that taxanes, sometimes patients will switch from positive to negative. But it seems like also, I've seen some data that in abiraterone and enzalutamide, the patients will switch as well. Could you comment on that, how longitudinally, how patients convert back and forth?
Right. So in our first paper, we made the bold statement that anyone who was positive and then they received the enzalutamide or abiraterone remained positive, and that was true in the first 18 patients. But we have now seen a very small proportion of conversions from positive to negative during ENZA or ABI treatment. We see much more of the positive to negative conversions on taxanes. So with taxanes, about 50% of patients actually convert who are baseline positive to negative. With AR-directed therapies, the conversion is about 5%. And that might simply be an artifact of the test. For example, when we make a positive call, it's a threshold effect. So if we have potentially minute amounts of AR-V7 or a very small proportion of AR-V7, if it's below the detection limit, we might call that negative. And then if it's above the detection limit, we call that positive. So the way that we make the call is basically 36 PCR cycles. If we can get an amplicon in less than 36 cycles, we call that as positive, and if it's above 36, it's negative. So we've had patients who go from 35.9 to 36.1, and so that's essentially the same. But in that case, it might go from negative to positive and positive to negative. But it's a good lesson. It's very complicated. I think sort of evolutionary forces are at play here. And of course, when you use an agent that very strongly targets the wild type canonical AR, and the cell still wants to, is still addicted very much to the AR signaling, it's going to produce splice variants. But then if you remove that pressure, maybe just by simply stopping the abiraterone, that person might convert back to negative, or maybe by giving them a taxane, or maybe, as John's going to say, by giving them high-dose testosterone. And maybe we're just reversing evolution, and we're not really seeing markers of resistance. So that's the part that I'm really confused about.
Yeah, just where it kind of builds on that, since you're using the circulating tumor cells, is it possible also that that is a subgroup of cells that, in other words, because it's very interesting that you'll have responses in people, because you'd really expect a true AR variant never to respond. I mean, it makes sense since the target isn't there. So is it maybe that there's a subset that is circulating that may not reflect what's in the tissue?
I mean, both the cell search and the ADMET test technologies rely on EpCAM, so we're not really getting any of those EMT cells or mesenchymal cells. Now, the Epic Sciences platform, which basically spreads cells on a glass slide and then uses computer algorithms to visualize them, that would potentially pick up other types of sort of mesenchymal EMT cells as well. So yes, this assay was biased towards the sort of epithelial, carcinoma cells.
Yes. Hello. You have so you have this mRNA threshold in that then associates really nicely with clinical outcome. But do you know whether the V7 is coming through alternative splicing or through genomic rearrangements?
Well, in our study, we didn't do that because we only did biopsies on 7 of the patients. But a lot of other studies have looked at that. Genomic rearrangements are very, very uncommon in human CRPC. In fact, the 22 RV1 cell line has a genomic rearrangement. The other AR-V7 expressing cell lines like VCAP or LinCap95 do not. It's probably not a genomic rearrangement. In the vast majority of human CRPCs, it's probably a splicing event.
So, Emmanuel, great talk as usual. There's so many variants. I've lost track of how many. V7's 1.
22.
What about all the others?
So if you look at the that Roberts Cell paper that was published on May 18th,
Right.
The last authors were Shanayan and Sawyers. If you look at, they didn't even talk about this. It's figure 4B. It's the RNA-seq of the 125 CRPC biopsies, and they had this nice figure. I think Steve Plymate made the figure. And they show all 22 of the splice variants that were detected by RNA-seq. The most abundant one was AR-V7. In other words, it was found the most often. Now, don't forget, with RNA-seq, if you have one single copy read of that RNA, that's called positive. So all you need is one copy read. So they found AR-V7 in like 90% of the 125. All that meant is that at least one copy of the RNA. The second most abundant was V1. The third most abundant was V9. And the fourth most abundant was V12, which is also called 567ES, the exon skipping. And it's actually ironic, but those 4 are the 4 main ones which are known to be constitutively active, and the rest are either conditionally active or inactive. So it's kind of perhaps not so serendipitous that the 4 splice variants, which were the most abundant in human CRPC tissue biopsies, are also the ones that have been shown in preclinical studies to be the constitutively active ones.
But I think sort of the question I was implying that you've got some folks who are V7 negative. I mean, certainly I would imagine you've been looking at assays on the other variants to explain. Do you have any progress on that?
Well, we do, and actually Avi Janakaku at Cornell has developed her own assay, which is a multiplex PCR, and she's looking at 4 variants at the same time. And the thing which I will say is it's extremely uncommon. We've only found, I think, 1 case or 2 cases where we don't find V7 and yet we find another splice variant. In other words, for another splice variant to be detectable in a human tissue, either a CTC or a biopsy, it looks like the V7 has to be present, and the V7 is almost always more abundant in that patient. The Dan Haber group published a paper about a week ago, it was mentioned, looking at single-cell RNA-seq, and they basically looked at 13 patients. And if you look at his paper, I think there were 2 examples of cells that, using at the RNA-seq level, they found AR-V1 or V9 without AR-V7 in that one cell. So it probably does happen occasionally.
Keep doing good work.
Thank you. Thank you for your very fantastic talk. How similar are the error variant? How similar are these 22 error variants? Do you have any idea?
Most of them at the protein level would be expected to comprise the first 3 exons, and then there's a truncation at some point after that. Exons 4 through 8 encode the ligand binding domain, and almost all of them are missing either the entire ligand binding domain or a big part of it. But most of them are basically, the protein that they would be expected to make, although the protein has not always been documented. It would be expected to be basically a premature stop after the first 3 exons and then maybe a little bit more. So they're similar structurally, but they're not all constitutively active.
So all of them had the N-terminal, right?
Yeah.
Thank you.